So in this study we found that, the major conclusion was that patients who have diabetes with heart failure, who are in sinus rhythm, benefit from beta blockers, and they had 20% reduction in their all-cause death rates over just a period of about 1.5 years of follow-up. So very significantly, patients with diabetes should be given beta blockers as part of their heart failure treatment. The second major part that we found was what other studies have shown, which is that perhaps they have a lower benefit than non-diabetic patients. We think is pretty much all due to the interacting features of obesity. And we found that the obesity paradox was quite evident in our study, wherein patients who are obese tend to have less bad outcomes than those who are not obese. Now that paradox has been demonstrated in lots of different studies across different cardiovascular diseases, but in particular in heart failure we think it's an important interaction with diabetes. So those are the sort of the main two big highlights of our study. So there's always been a concern from clinicians that perhaps certain drugs that we use for heart failure with reduced ejection fraction don't work as well in important subgroups. And so we've done a lot of work on age and gender, but one of the big remaining ones was diabetes. And that's not surprising. Diabetic patients obviously are more likely to have bad outcomes in combination with heart failure. And they're making up an increasingly large proportion of patients. But of course the other big thing that's happening is obesity, and we have to be aware that that's a global epidemic now, and diabetes and obesity are particularly connected. So our hypothesis was that perhaps obesity is part of that relationship. That, as far as we know, has never really been explored, and of course to do it properly you need a large database, large numbers of patients. And because we also wanted to then look at the effect of beta blockers, it's important that those studies are randomized, but also very importantly they're double-blinded, because what you don't want are clinicians to change their practice of what beta blockers they give, etc., because of the patients they see in front of them, and those are all observational biases. So we used double-blind randomized controlled trials, 9 such trials with a clearly defined prospective program. They were all systematically analyzed. We went back to original case report forms for individual patients. So this is an accumulation of nearly 14,000 individual patients with either diabetes, obesity, or neither, with heart failure. And we restricted the analysis to sinus rhythm because we've previously shown in a paper we published in The Lancet a few years ago that patients with atrial fibrillation don't seem to benefit from beta blocker therapy. So we presented 2 main groups of results. The first was purely on prognosis, so what factors are associated with all-cause mortality and cardiovascular mortality in patients who have heart failure, predominantly with reduced ejection fraction, and who are in sinus rhythm. So that's the sort of the first group of results that we presented. And that was very clear that diabetic patients have increased mortality. That's not a surprise compared to non-diabetic patients. We confirmed the obesity paradox, that patients who are obese tended to have less mortality events than patients who are not obese. But really very interesting, we found that those 2 interacting factors almost crossed each other out. So when patients were both diabetic and obese, in fact they had the same risk of mortality as if they had no diabetes or no obesity, and that was about a 10% mortality risk every year. So that was the first sort of group of results that we looked at on prognosis. And then we went on then to look at what happens with the effect of beta blockers. And again, important to remember, these were double-blind trials. These were all randomized on the basis of beta blockers or placebo. And we found that diabetic patients have a very significant reduction in their all-cause mortality when they're given beta blockers. In fact, there was a 20% reduction in the hazard of death. Now that compares to about a 30% reduction in the non-diabetic group. And our analysis suggests that the reason for that difference is probably the very high rate of obesity in the diabetic patients. So if we then look at the obese outcomes, We find that non-obese patients, again, have a very significant 30% reduction in mortality, but those with obesity, we couldn't find a significant reduction. There was, of course, a trend to benefit, around 15% mortality benefit, but even with 3,000 patients, it wasn't significant. So that just highlights the fact that that obese group is something that we really need to spend more time on and work out how we can improve outcomes in those patients. So the first thing, and you know, it's very clear from our data that all diabetic patients should be given appropriate guideline recommended therapy, and that includes beta blockers. So this concept that higher risk patients, and of course diabetic groups are much higher risk, seem to have a lower rate of prescription of these drugs. This is something we need to challenge, and we need all physicians out there to really go ahead and prescribe therapy. Now the second bit is more translational. It's trying to understand from a scientific point of view why obesity interacts with diabetes on the effectiveness of these drugs. And it may be that that's the case for other heart failure drugs, you know, we don't yet know. But that's something that I think from a translational point of view we need to explore further. And there's some good reasons why that might be the case. And you know, we outlined some of those in our study. But I think at the moment the crux of the matter is that we don't really know. And we certainly need more research into the interaction of diabetes and obesity into the context of heart failure.